synapses, number of synapses increases and their functionality increases. And so likely a lot of the effects, the beneficial effects we're seeing from ketamine are due to this neuroplastic effect that the drug has. But they're highly dose dependent, and we see a lot of variability within patients. So there's still a lot of open questions there. And I'll hand it over to Dr. DeLeo to really cover the clinical side of this.
All right. Can you guys hear me now? Sounds good. Thanks so much, Marshall. I think this might sound like a bit of a non sequitur at this point, in part because I'm going to try to broaden the conversation beyond just kind of the biological determinants of how ketamine might work and support these therapeutic outcomes, and think more holistically about the exercise of psychotherapy and what it means to work with clients specifically. I think it's really helpful to think about healthcare from a biopsychosocial, dare I add, spiritual perspective. And this really is an interdisciplinary perspective that acknowledges that there are biological facets, psychological facets, and socio-environmental facets that contribute to health and well-being. There is a wonderful, I think, history, certainly in psychedelic psychotherapy, that acknowledges that in many respects, we often lack a language around how to describe what's going on. I think Marshall was quite humble. I think slide number 2 may have kind of freaked a few of us out. Maybe I'm speaking for myself, but no doubt, I think there's a lot to be learned about the molecules themselves. And there's so many questions, I think, that remain still from a biological perspective. But I think when it comes to working with the kind of therapeutics of it, we need to really understand how the biologics support the psychological and sociological facets as well, so that we can perhaps more artfully assist individuals in describing the ineffable qualities of psychedelic psychotherapy that some describe as spiritual. So I see the exercise on healthcare as being one of well-being that includes all of these facets. I'm sure we've all heard about the kind of classic set and setting when we think about psychedelic psychotherapy. I really wanted to kind of just illustrate that we're absolutely sensitive to this, in that we're talking about internal and external context here. So of course there are the drug effects to consider, the type, the quality and dose, frequency of administration, and also more broadly, availability and accessibility, which understandably can be a real problem in certain regulatory formats. And also certain legalities prevent individuals from being able to fully capitalize on the potential benefits, or even explore and research what these benefits might be. Naturally, when we talk about set, we're really talking about the individual and what they bring to this experience. And that could involve just a really thorough understanding of their health status, their motivations for use as well. And when it comes to therapeutic processes, facets like stages of change, which I'll elaborate on in a moment, come into play, recognizing that these experiences are quite potent and in many respects can be transformative or traumatic depending on the setting for individuals. And lastly, around the setting, that's typically the when, where, and with whom the medicines are being used. And that's super important, you know, whether you're riding a bike or at a dance club or in a clinical setting, there may be different effects that are experienced by the individual who's made use of these medicines. So I'd like to just talk just more broadly about integrative psychotherapy and kind of the approach that we're exploring at Field Trip Health. So integrative therapy is a progressive psychotherapy that really combines different approaches and different therapeutic tools to fit the needs of the client. And we're really trying to capitalize on a solid understanding of human development, so that the integrative therapist can modify standard treatment approaches to fill these developmental needs depending on what the client is presenting with. So when we combine different elements of various schools of psychological thought, treatment, and research, integrative therapy becomes more of a flexible and inclusive approach to treatment, more so than a traditional or singular form of psychotherapy. So we're really trying to go beyond kind of pathological models and consider the person in a more holistic sense, and also an ecologically sensitive manner. So the emphasis really largely is on the therapeutic alliance and relationship, as well as the kind of the integration, so to speak, of the treatment methods that are used for that specific client. And when it comes to working with clients, it's definitely not a one-size-fits-all. That would be a terrible way to represent the 7 billion individuals as diverse as we are. So we recognize that there are different ways in which we can match different treatment modalities based on clients' needs flexibly across the course of treatment. So it does give some flexibility also in how the therapists themselves bring themselves to the work, and what tools they've learned have been helpful depending on the presenting problems and challenges that individuals are bringing to therapy. So the therapist works collaboratively with each client to create a new therapy, so to speak, based on key principles that we've come to understand work in supporting well-being. So at Field Trip, we are starting with ketamine specifically, as it is the only legal psychedelic medicine that we're able to use in this capacity. And the program that we're developing is an integrative ketamine-enhanced psychotherapy program for depression. So I'll try to unhash some of these key components that we think are central to our process. At its heart, it's a client-centered approach. We recognize that the decision-making insofar as the therapeutic decisions are predicated on what's best for the client. And that acknowledges that they have autonomy in the decision-making. This is not trying to fit clients into treatment, but rather trying to understand the client's needs specifically. It's a person-focused approach in that we recognize the person is at the heart of this process. A lot of us talk of self-psychology and various ways in which we can integrate aspects of the self. So we recognize the strengths that people bring to therapy, not only the limitations that they might see or their problems or so-called challenges. It's a values-based approach, recognizing that our values change moment to moment as we prioritize our daily lives and things change in life. So we have meaningful conversations about the values that people have and wish to express. And we've learned that essentially in many cases, when individuals are experiencing depression, they feel disconnected from their values. So it's often a really important facet of our work to engage them in this way and get a clearer sense of what would be useful to them so that we can greet them in the conversation on their terms. Given my training, I certainly feel that there's been a lot of wonderful work done in psychotherapeutic and clinical treatment research. So our treatments are evidence-informed. We emphasize experiential learning, recognizing that experiential avoidance seems to underlie a lot of so-called pathology. The approach also is transdiagnostic in that some of the qualities and components of the treatment can be used for more than, say, just depression. Anxiety and, say, trauma conditions often co-occur, so it would be fairly limited, in fact, if we were to use a diagnostically focused treatment approach. We want to make sure that it's practical, accessible, and flexible. Folks come from all walks of life, different reading levels and lived experiences. So we want to make sure that individuals understand the rationale of what we're doing and that they can, in some sense, direct the course of treatment. It's inherently collaborative. It requires a lot of dialogue, and it's certainly interdisciplinary. I work alongside folks like Marshall, who have a clear sense of the biological underpinnings of this work, and registered psychotherapists are fantastic insofar as applying some of our understandings in a clinical capacity. So in a broad sense, we're really trying to identify, we're trying to help individuals identify, express, and engage facets of what will support them in their well-being. A word comes to mind, eudaimonia, which is the notion of supporting human flourishing. And I think that's kind of a philosophical direction that we hope to go with our clients. I'll speak very briefly about proposed mechanisms, in part because I think we ought to be able to do so. As Marshall was describing, that ketamine in some sense can be an important catalyst that supports neurological growth. And we, in some sense, think that it primes the brain for new insights in experiential learning. And we think that in an appropriate context, it offers clients a safe and therapeutic window for them to collaboratively work with trained therapists in identifying, expressing, and engaging their values. And together they can translate these insights into meaningful and purposeful value-based actions that can contribute to that eudaimonic life that we all aspire towards. So it's a synergistic approach that hopes to extend the antidepressant effects of ketamine and also reinforce self-efficacy, one's own sense of capability, as well as help them engage in important life areas in support of their overall physical and psychological well-being. And I just wanted to kind of briefly kind of share that this question is like, what are we integrating? And sometimes therapy is a black box, and I think there's been a lot of folks who have made some effort to describe integration. What I've shared today is just one way of thinking about it. But this slide really is just to represent that we're multifaceted beings, and we're certainly sensitive at that. So we're hoping to support individuals in acknowledging various aspects of their experience, whether they be physiological or affective, cognitive or behavioral, and also to make room for those transcendental or peak ones, those non-ordinary states of consciousness that no doubt can be experienced with the facilitation of a molecule like ketamine, and or in ordinary life circumstances when we experience loss of life in a loved one, or perhaps a major life milestone or so on. So I'm not sure I'll have a lot of time to go through the stuff of our experience, but it's an interesting way to kind of consolidate some of the ways in which we might query an individual, say, after they are re-entering from a dosing session. The acronym STUFF refers to sensations, thoughts, urges, feelings, and flow. And these are a way for our therapists to make sure that we are broad enough in our conceptualization of all that can happen and all that's going on in someone's moment-to-moment experience, so as to help them kind of bring that to the surface, help them breach into awareness so they can start to make meaning and make some sense of the experience. I'm happy to answer some questions if they come. Thanks, guys.
Sure. Thank you guys, first of all, for that presentation. It was great to kind of see both the preclinical and clinical side of your work. I think we have one question right now in the chat. This one is directed to Marshall. And the question is Field Trip exploring the combination of ketamine and rapamycin or other mTORC1 inhibitors?
No, right now we're not. So it's actually very difficult to explore drug combinations like that. We talk about it a lot because we would love to explore certain combinations. I think, even within the pure psychedelic realm, there are lots of drugs that could be combined to have really efficacious effects. For example, if you gave someone MDMA and then following an MDMA session gave another psychedelic such as ketamine or psilocybin, it might actually enhance the efficacy and the openness of the patient. But unfortunately, that's difficult to do, and everything we do is evidence-based, and there's just not enough evidence to support that kind of combination yet.
Yeah, awesome. Thank you. I think the second question is not directed at anyone specifically. So it says, in psychedelic therapy, the plasticity and experience last for many hours, which seems important for taking advantage of plasticity. The more time under plasticity with experience, the more potential for reprogramming. So I guess the question is, how does ketamine compare in terms of the plasticity window and type of experience?
Well, that's a challenging one. I mean, I'll take a shot, and it's I can probably speak more so insofar as what we're trying to capitalize on. We do recognize that there's potential for growth and learning. I think that's a kind of a general sense of acknowledging that brains are plastic, and certainly not in the literal sense, but brains are constantly changing and evolving and developing new pathways synergistically. Ketamine seems to, in some sense, facilitate this. I think sometimes the kind of fancy word that I get to use occasionally, not generally with my clients, but sometimes is kind of these synaptogenesis, where you kind of see this proliferation of dendrites, and seems to be some indication that there's this neuro-seeking of sorts for new connections. So I really don't know about the window, so to speak, but we do try to capitalize on a structure insofar as how we do the therapy, which is we focus largely on preparation to help individuals with that setting work, so they can acclimate to the work itself and with appropriate expectations of what might come from it. And then ultimately capitalize on the exploration that happens with the dosing. And we do pair our therapy with the dosing. So once an individual has gone on the journey, so to speak, when they re-enter back, we are there for them, we are responsive to them, and we help to capitalize on whatever insights they may have been able to discern during that time, and see if we can crystallize that into something that could be actionable or something that is meaningful and purposeful. Sometimes folks are ready to talk and to express. Sometimes they need some time to themselves. There's a lot of variability there, which is why I think the approach needs to be idiographic and flexible. And we do actually, we do take some time to recognize that integration is not something that just happens after dosing and say in the focus therapy sessions that follow, but it's a lifelong process. So it's important, I think, for us to recognize that this might be a catalyst of sorts for change, and but we're under no assumptions that it is the end-all be-all of, say, managing these chronic refractory mental health conditions, and or just a purposeful life worth living. So.
Okay, I think we have a third question here that was asked by two participants, and they were wondering how much of the work done at Field Trip will be shared with other therapists to learn from what you guys are doing.
We're doing it right now. This is a bit of a brave new world for me. I don't spend my evenings on webinars, but I do see there being tremendous benefit in having these conversations with folks, in part because it fills my cup up. I learn a lot from other approaches. As I mentioned, there's a rich history here, so we're not trying to reinvent a wheel. We're trying to capitalize on what we've learned through experience. Our greatest teachers tend to be our clients, so I tend to let the data be my guide in that sense. So we're happy. We're very much set up to capture the meaningful experiences that clients share with us. We also value data, so we're making some efforts to put in place data systems that will help us articulate our process and the outcomes, so that it generates both intriguing dialogue about what we're doing and also considering ways how we can improve it.
Okay, we got another question here that's kind of looking at the difference in ketamine and a couple other drugs. So besides being legally available, is there any benefit to ketamine over other drugs classically used in psychedelic therapy like Mdma or psilocybin?
Yeah, so I think that's a great question. I mean, in terms of mechanism of action, certainly there's a difference in that ketamine acts on the glutamate system, whereas drugs like psilocybin and Mdma are more directed towards the serotonin system. But in terms of overlapping sort of experiential factors, there's definitely a lot there. All these drugs can cause psychedelic experiences, and if we look at psilocybin as one of the prime examples, it's been shown that the intensity of the psychedelic experience is heavily correlated with the outcome. So the more intense this mystical experience is in patients that get psilocybin, the better their outcome tends to be. The same is possibly true for ketamine, but ketamine actually hasn't been looked at as a psychedelic in that way for such a long time. So the original studies that showed it to be effective in the case of depression were using a low dose IV over a long period of time. So it really wasn't at that true psychedelic level. So it's like giving a very low dose of psilocybin, for example, which the studies right now are exploring high doses of psilocybin. And we think there's probably a lot of benefit in high doses of ketamine by allowing patients to achieve that transcendental peak type experience that's so conducive to a good outcome. So, I mean, it remains to be seen how much the experience matters, but data so far is suggesting that it probably does matter a lot. And we think that there's a lot of overlap in the experiential components of ketamine, psilocybin, and all psychedelics.
Okay, great. We've got quite a few more questions. Sorry, everyone, if we don't get to them all. There's a question here more so talking about the chemistry. So is it true that the S-chiral stereoisomer is on the market? And if so, what are the implications for cost and accessibility? And there's a later kind of follow-up to that about how can we work on advocacy initiatives for the accessibility of this important treatment.
Did you want to speak to that, Marshall?
Yeah.
The availability of the medicine itself?
Sure. I can talk about that a little. So, yeah, the S enantiomer is currently on the market as ketamine. It's marketed by Johnson & Johnson, and it's an intranasal spray. It actually didn't show the same sort of efficacy that IV ketamine was showing, the racemic mixture of ketamine was showing. So it's possible that something was lost either in going to the single enantiomer or in going through a different route of administration, the intranasal versus an injection. And so there's still a lot of open questions there. And I mean, ketamine's a generic drug, so it can be prescribed off label, and the drug itself is essentially free when it's used as a racemic mixture. And so that should lower barriers to entry. But the one thing that does create quite the barrier is the necessity for psychotherapy. And a lot of these clinics, especially in the US, aren't actually doing the psychotherapeutic component. So they're just infusing patients with ketamine and then sending them on their way without really integrating the experience. Mm-hmm. But if we've learned anything so far, it's that integration component is so crucial towards changing behavioral patterns and changing those thought patterns that are have really locked patients into these depressive states to begin with. And so I think that's a barrier to entry that we're going to be constantly working on lowering as much as we can. And I don't know if you wanted to speak, Dr. DeLeo, a little bit about efforts we're taking to that end.
Mm-hmm. I just wanted to compliment one of the things you shared, Marshall, which is that the medicine is an incredible medicine, no doubt. And I think I'm very much a student of these medicines more generally. And in terms of accessibility, just as it was with cannabis, many people really weren't asking for permissions to use it. It was in fact a reality, and folks seek out opportunities to treat themselves, so to speak. I think there's an opportunity here in us being able to demonstrate the efficacy and the effectiveness of these medicines. And my hope would be is that in us being able to do our due diligence and ensuring that these are safe medicines and they're effective medicines, it will garner attention that will otherwise lead to important movements that will support access for those who otherwise could benefit from it. And I do think that there is a tendency or maybe a fallacy to think that these medicines can be curing agents. And perhaps they can be. Like I will always maintain some element of scientific equipoise and be pleasantly surprised if that is the case. I work very hard for my clients to fire me in some sense. But I think the emphasis needs to be on not so much on curing, but more on caring. And I think the caring is of well-being and welfare. And it certainly comes at a very important time in our history with multiple pandemics happening, both biological and sociological. So there's a lot of work to be done there. And I think I'm happy to take some responsibility for that work.
Okay, we got another question here. So given how depression is very often comorbid with other mental illnesses like anxiety and PTSD, is there any evidence that ketamine is shown to be effective in any of those other mental illnesses, or is it just purely with depression?
It's a great question, and it's an empirical question, but there are those who are doing this work already. And as far as the work that's been shared with us in the literature, as you pointed out, that these are often comorbid conditions, right? It's rare in my clinical practice to see someone present with, say, depression. Anxiety tends to be a precursor to depression in many cases, or often co-occurring alongside it. Trauma is a multifaceted construct. It deserves its own attention, and in fact, we're very sensitive to this, and we've built a very thorough consultative assessment process to make sure that we're not missing any of the facets that could be contributing to human suffering in that sense. So in that sense, the work that's been done in this area invariably has been working with folks with co-occurring or concurrent disorders, so to speak. In our own work, we're finding that those who are coming into our clinic with primary depressive conditions also have co-occurring anxiety, also are presenting with various facets of trauma. I mean, if you live life long enough, or if you just take stock in kind of the impact that daily living can have, we're all, so to speak, at risk of having lived experiences that leave impressions, some less than helpful. So I'm optimistic that we need to kind of broaden our scope beyond just diagnosis and think more holistically about the individual person, and whether that be depression, as we tend to conceptualize it, or just distress and dysphoria. There's a lot of rich work that can be done with folks who are open to the process of working collaboratively with someone who has their care in mind. And with these very potent medicines, it certainly accelerates the process that I often find myself in psychotherapeutically in the absence of these medicines. So there's a lot to be optimistic about, especially in light of the constraints people face in, say, maintaining access to psychotherapy, which can be quite costly and in some cases limited. So to have an agent that could be catalytic in this sense and expedite a process, so to speak, or at least facilitate it, that's quite exciting.
So there's another question here more related to side effects of the treatment. So with higher doses of ketamine, do patients have issues with recollection of their experiences after the session? And there's a follow-up to that. And do you know if there's any relationship between recollection and clinical outcomes?
Great question. Great question. I'll take a shot at this, and Marshall, you're welcome to piggyback off it if you got any more you want to share. Memory is an interesting construct itself, and especially when we're talking about trying to manage or address trauma-related conditions. So there are various ways in which I think you can approach dosing so as to ensure that individuals find the experiences meaningful. And at least in our experience, it's the approach is to, you know, start low and go slow, and to find that optimal dose that otherwise is going to facilitate a psychotherapeutic process. We find that when individuals are not able to recollect for whatever reason, it could lead to somewhat of an impoverished dynamic, so in the therapy itself. You know, there may be good reasons to, in some cases, or at least in addressing certain conditions, to have, let's sort of say, psychedelic experiences where memory isn't the primary component of what an individual is bringing back from the session, but more so kind of the sensorial or bodily experiences. This is not just a cognitive exercise. So we recognize that there might just be different applications for dosing, whether it be psycholytic processes that are facilitated by lower dose ranges, or more the kind of psychedelic doses that lead to these more transcendental or kind of mystical or mystifying experiences.
Yeah, I guess, I mean, what I'll add to that is that ketamine's been used as an anesthetic for so long, and there hasn't been any sort of strongly noticeable correlation between the use of ketamine and anesthesia and antidepressant outcomes. And it would be thought that after so much use, you'd realize there's some antidepressant effect. But I think the fact that these patients aren't really experiencing ketamine because it's such a high dose under anesthesia probably takes away from the overall benefit. But it is an open question how much the experience matters and what components of the experience are really crucial to achieving the outcome that the patient is looking for.
So I think we're going to take one more question. Sorry, guys, we didn't get to all of them. So this question is more geared towards people that have, say, non-pleasant experiences during the therapy. So do you guys have any steps for people that are facing challenging experiences and people that feel like very overwhelmed during the therapy when you guys are conducting the sessions?
Great question. We have no prohibitions on any experience. In fact, in many cases, sometimes the more challenging and difficult experiences can be the most meaningful and useful to the individual. So we don't tend to conceptualize things as good or bad trips. It's not kind of our language about it. We do our best to work through and work with whatever comes up. So we are absolutely sensitive to that. I think this is where having skillful practitioners, therapists who have can normalize some of the disruptive or kind of jarring experiences that could accompany a psychedelic experience. It's critical, I would say. I think this is we've all learned from either anecdote or just in some of our readings that in the absence of an appropriate setting and with a caring and supportive and skillful, caring, compassionate, competent individual, it really could go wrong. And there is probably a fine line between transformative and traumatizing, I'll say. And I think context matters. So that's why I think when we have these conversations, as much as it's interesting and fascinating to consider the effects of the molecule itself, it really has to be thought about from that biopsychosocial, spiritual perspective for us to adequately contain the richness of a human experience that might be provoked by a psychedelic experience or inspired from one.
Yeah, and I think the only thing I'd add to that is, so as Joseph alluded to, we do everything we can in terms of optimizing the setting so that a patient has a positive experience, and positive being anything that leads to a beneficial outcome for the patient, anything that they're looking for, which doesn't a good trip or a bad trip. But, you know, there's still open questions when it comes to optimizing that setting. And that's true for any psychedelic work right now. These molecules have been used for millennia, oftentimes not in the case of ketamine because it was introduced in the 1950s, but molecules like psilocybin, mescaline, whatnot have been used for millennia. And they've been used in different settings, and it's still not clear what the optimal setting is. And it's likely still highly dependent on the patient and the particular diagnosis they come in with and the particular outcome they're looking for. And so there's still so many nuances to it that don't really fit into a typical medical model. And we don't profess to understand all of that. There's still so much we have to learn. And we're just at the start of that learning process, taking what we can from the past and hopefully pushing it forward a little bit.